All right, last, final session. We'd like to bring Jenny and Mark up. Thank you. And maybe I feel like I see people walk in, like, I know it's tough when you have like an end of a session and we're still going. So I almost feel like this might seem goofy, but like people should stand up and stretch for a minute or like take a second. Like this is a lot of information to take in. And as Jenny and Mark get set up, I just want to, I guess, say to everybody again to remind you that this work, these conversations are really important and essential as we look forward and try to leverage the technology and avoid racial bias in AI. Okay, so I'm hearing some murmuring. Why don't you guys murmur for 60 seconds? I'm gonna like channel my dad thing. You guys take a second for yourselves, murmur, do whatever you need to do, and we're gonna be right here. No, no. They might be live right now. Don't turn it on. Yeah, and then yes, that's not happening at all. Yes, that's not happening. Okay, I'm going to give these people to like 10:58.
Yeah, give folks a minute.
Yeah,
it's a lot to do back and forth. A little bit. Like people do much go to rest. I know, it's the whole thing. Question for you. I see that you've combined the OCR role and the introduction. Do you want me to do that together or bifurcate it? I had imagined it would be bifurcated just because I don't think folks know what OCR is. So I want to kind of give a little overview rather than diving into the AI portion first. Okay? So can we tweak that a little? Just to say, can you explain, like, who are you and also what is OCR? Because I think FDA, and this is an ONC conference, people know, but OCR is the stepchild. Okay. Just because we do a lot more than AI.
Yeah, no. I think that's really smart.
We'll do big.
Yeah, okay, right. So the first thing that you introduce yourself, name, and just even.
Yeah, exactly.
Right, okay. So everything's going to be sort of more condensed. Because, like, lunch is at 11:35. We can go till like 11:35. So that's fine. I'm fine. Okay. All right, everybody. I hope folks have had a chance to stretch their legs and check out your phones and talk to your neighbor and kind of like figure it out. But Jenny and Mark have put a lot of time and effort into actually what we're about to talk about. We've put a lot of time into this, so it'd be really great if folks could come back to your seats, settle down, and settle down's rude, I apologize. Just be quiet, maybe that's less rude, I don't know. But if you guys could give us our attention, I'd really appreciate it very much. And I'd like to introduce the final of our 3 conversations with federal agencies today, and we're gonna sit down here and get this going. Thank you very much for your cooperation, really appreciate it. So, oh yeah, thank you, go a couple, yeah. All right, let's get that applause going, woo! Yes, all right, fantastic. Jenny and Mark, could you guys introduce yourselves? Mark, why don't you just start, name, title, quickly tell us a little bit about you.
So, hi everybody, my name is Mark Sendak, and I work for the Duke Institute for Health Innovation. I'll speak today and share comments with kind of 3 perspectives. My dominant one is helping lead internal innovation teams at Duke that build products, new care delivery models within the system. I also am a co-lead of Health AI Partnership, which is a multi-stakeholder collaborative that focuses on healthcare delivery organizations and capacity building to help health systems safely, effectively, and equitably use AI. And then the third is I am fortunate where we have multiple licenses to external companies to scale solutions we've built. So I have seen how these tools are scaled beyond my own organization into other healthcare delivery organizations.
Great, thanks. Jenny?
Good morning, everyone. My name is Jenny Ma, I use she, her pronouns. I am the Acting Chief of Staff and Senior Advisor at the Office for Civil Rights at U.S. Health and Human Services. And
real quick, Jenny.
Yes.
What is the Office of Civil Rights?
That's right, because you all are at an ONC conference, and I'm sure you know what ONC is, and I think if you walk out of the hotel, most folks know what FDA is. But just by a show of hands, how many people know what OCR? Oh, good. Okay.
Oh,
this is better than
that's
usual.
not what you thought.
Very nice.
I feel like
Not
that
my
was
HHS
everybody.
colleagues over there. No, that's great. So I'm really glad to hear that. Part of my portfolio at the Office for Civil Rights involves non-discrimination laws, which we'll be talking about, but also AI. And we'll also be discussing Section 1557 of the Affordable Care Act, which I'm sure many of you commented on. And I'll have one caveat, and I'm not trying to be a government person here, but because we are in active rulemaking, obviously there will be some curbs and curtails on what we can discuss specifically there. But I'm looking forward.
Lots of it depends.
Yes.
Lots of it depends.
Of Troy's line of it depends. Yes, indeed. But great to meet everyone, and thanks for bearing with us on this last of 3 sessions.
Great. Thanks for that, Jenny. So let's start with you, Jenny. OCR is the agency here today that is closest to the actual patients. You're regulating the clinicians, the health systems, and the insurers. From that vantage point, what is OCR seeing that is concerning when it comes to bias and AI? What have you all seen in the field? What have you seen in the wild?
Sure, and I think this harkens perhaps to Christopher's question about the application of the technology. So I'm sure many of you know, but just to kind of level set, the Office for Civil Rights regulates providers, healthcare facilities, hospitals, and so we are the closest to the patient in this way, just as Mark has described. We rely on not only the enforcement actions that we take under the 55 statutes that OCR regulates under, but we also rely on complaints that come in that describe specifically what is happening on the ground, because we are able to then investigate what is going on and regulate and provide industry and the public with guidance. So we'll talk much more about that, but in this space, AI is emergent. I don't want to beat a dead horse, but we all know that there's a needle to thread in this area. For OCR's perspective, we started seeing, we obviously know that healthcare is laden with inequities. As an Office for Civil Rights, this is not new news to us. It's laden in disability, which is under our purview, age discrimination, racial, national origin biases, and in gender and sex. So we get complaints across the board. AI has existed for many decades, as the commenters made note of. But where it became most acute, I want to describe 2 spaces for OCR. The first is during COVID. Obviously, as we all know, inequities that were pre-existing became even more amplified. But we saw in crisis standards of care, particularly with age discrimination and disability discrimination, an incredible uptick where very scarce resources were being allocated unfairly and in a discriminatory manner. So what OCR did, and I hope this is kind of the theme that I want to get out to the public today, is that we did not do punitive actions in that, obviously public health emergency. We worked with states to figure out how to develop fairer policies that would not discriminate, and then issued a guidance accordingly. So, we learned from a tragic incident and an incident of discrimination. We worked with the states and the providers to abate, and then we issued guidance to abate further if you were not the ones that were officially in touch. And then I would say we are an enforcement agency. We're in law enforcement. I hope that doesn't sound scary. I hope that we are always thinking of voluntary agreements, the spirit of collaboration. But because we are a law enforcement agency, we see all sorts of discrimination that is occurring within the AI space and elsewhere. So, when we were thinking about this panel, my team kind of pulled examples of the complaints that we had gotten in this space in AI. And, I would say, a fraction of what we actually have in our enforcement bucket, but it was, single space, dozens of pages. So we have in our enforcement teams and enforcement side of things, just examples after examples of different ways in which this developing technology has been already, we're seeing complaints of discrimination. So those are the two instances I want to point out.
And Jenny, we talk. We also had like 28 background calls with these guys. I mean, maybe 34. Can you just tell the people in the room, like a lot of these conversations this morning, as important as they've been pretty high level. And one of the cool things about having OCR on this stage, frankly, is that you are closer, again, to these patients, just as you said a minute ago. Can you please share, because this is real stuff that is happening right now. There is discrimination, there is bias, it exists and it is alive. This is not just an intellectual policy conversation. I was reporting in Camden, New Jersey on Tuesday. There's real shit going down. And so I would really like for you to share with the people in this room a story or two quick stories of what that looks like, because it is happening and it is why there's urgency. And when people leave this room, you want them to feel urgent. You're going to make these people feel urgent by sharing a story.
Sure. Let's put a name to the face. Let's call someone Mary. Mary is a biracial patient that presents.
Wait, this is a real story.
This is a real story, not real names, and perhaps facts were changed a little bit. But Mary is a biracial patient. She presents at a hospital. She is in kidney failure, and in this particular hospital, there's pull-down menus that are singularly race. So I think Mickey had mentioned, right? If it's Black, it's white, Asian, Hispanic, and that's it. And so the provider and Mary, right, there's certain determinations that are made, and because the patient herself is biracial, the decision that is made by the provider then ultimately ends up with her having advanced kidney failure, longer periods of waiting time in order to get the care that she needs. This is one story of many that I'm sure you and folks in this room have been hearing, but that is one enforcement action that we have seen where, these decisions that are not only made by the human, right, because to the point of human bias, systemic racism in healthcare industry, all of that exists. And then on top of that, if the development of the AI that is making additional certain determinations is already so bifurcated, then we end up with these issues.
So you guys OCR put out a proposed rule last August. Briefly, what does the rule say when it comes to bias in AI? Just 2 or 3 seconds.
So this summer, Section 1557 of the Affordable Care Act is what I would call the kitchen sink non-discrimination statute, right? We all know what the ACA is. The non-discrimination portion lives in Section 1557, and a part of that, among many, many other things, and you guys all saw the notice of proposed rulemaking. It's hundreds and hundreds and hundreds of pages, but a section of that asks for comments on clinical algorithms, and I'll just read this because I'm a lawyer by training, and so the text really matters. The proposed rule states, quote, that a covered entity must not discriminate against any individual on the basis of race, color, national origin, sex, age, or disability through the use of clinical algorithms in its decision-making. And that's pretty broad. But I would also say that pre-existing laws right now, should cover that. So this is a law that, asks industry to comment. because this is such an emergent area, but you should not be discriminating in that health space as is. And we are aiming, without going into specific details again, because we are in the middle of rulemaking, our guiding principles here are three things. One, to make sure that the final rule is reasonable. We want to make sure that we are threading that needle, that we don't overstep in our regulations so that this is not feasible to implement. The second is applicability. We want to make sure that covered entities are able to actually understand what the regulations are, and they're clear enough to give you all guidance to implement in this space. And then finally, to have it be enduring. As we all talked about this morning, AI is an emergent space. It is increasingly changing. We don't intend for this rule and regulation to be set in stone such that there's no flexibility in its implementation, or that you guys don't come back to us and say, hey, there's a gap here, or you missed this, and of course, for us to engage in subsequent rulemaking. So those are our guiding principles here. We are working, burning the midnight oil to get this done, because I know how much different stakeholders, including those in this room, are looking forward to the rule.
Thanks for that overview, Jenny. So, Mark, you've spent a lot of time, I know, thinking about this rule. Jenny laid out, reasonable, applicable, and enduring. Does the proposed reg feel reasonable, applicable, and enduring to you as someone who's responsible for developing and implementing AI for a health system? How does this proposed rule strike you?
So I'm going to talk through the three, and I'll try to give kind of assessments of them. And I think as
star rating?
Yeah. Is CMS in the house? I don't know. But so I'll start with reasonable. And I know that Jenny and I bonded over this on some of our early calls. So I also worked exclusively on COVID for a 14 to 16 month period at Duke. Our entire innovation resources, personnel were kind of redeployed to build symptom monitoring tools, support pooled testing, support vaccine rollouts. And it was a very startling experience to really see firsthand how poorly equipped not just Duke was, but many health systems in the country to meet the needs of low-income, marginalized populations. And so in terms of reasonableness, I actually am very pleased that this is happening and that there is this enforcement and a regulatory agency drawing a line in the sand saying that this cannot continue and that we have to make sure that the way health systems practice is non-discriminatory, and shared lots of conversation about, there's a lot of other things that have nothing to do with AI that we still haven't seen the progress that we maybe should be expecting and changes in healthcare. But maybe AI is going to help us put numbers, measurements to things, and be more rigorous. So reasonableness, 5 stars. Okay.
Thanks.
Where we spend a lot of time is thinking about the challenges with applicability. And I know that Troy and Mickey earlier discussed kind of the need for standards development, coalition building. And this is where I think the approach that we've been taking with Health AI Partnership is a little bit different, because we really did start at the ground level. We were funded by the Gordon and Betty Moore Foundation to start to build capacity amongst health system managers who are, through their job roles, are responsible for developing and implementing AI in practice, the exact type of people who would be, candidly, pretty scared to sit up here with Jenny. And they have a lot of concerns when they saw this rule. And we do have diverse settings at the table. We have large AMCs, we have OCHIN, which supports 1,000 community health centers. We have patient representatives on the leadership team. So there are some specific things that we as a collaborative started to hash out pretty immediately. What does it mean to measure bias, impacts on health equity? I do think once we pulled people together and we actually did a workshop, we built a framework, because people were looking for that implementation guidance, the technical assistance to kind of take the rule and say, okay, now what can a health system do in practice to confidently feel like a technology that they are deciding to use is not going to worsen inequities or lead to discriminatory action. And so applicability, I would say, and I actually did most of these interviews. We did close to 90 interviews, health systems across the country. I asked people, how do you assess for bias or inequity? Everyone's answer was different. So just to highlight for Jenny, I think applicability, we have work to do, but I think the players in the provider space were already working together. So I think I view it as my role through Health AI Partnership to help with regulators make this applicable by developing the on-the-ground tools and support to help health systems know what to do. So currently 3 to 4 stars, but I see a future to get to 5 stars.
Oh, wow, 4, even 4. But can you boil, thank you very much for being as candid as you are and sort of sharing the insights you've had from the people that you're talking with, Mark. What's the, like in a sentence, what's the fear?
Oh,
why would people not want to be on this stage with Jenny right now? What are they afraid of?
I've had the privilege of getting to spend a lot of time talking to Dan. And one of the analogies that I arrived at earlier this year was, in many ways, you feel like you're walking in a field filled with landmines when you're building or implementing AI. And I know that Mickey talked about transparency and lemons. Most people don't know what to look out for in how bias or potential for inequity is baked into algorithms. And even every time we have found a new way of baking it in, sometimes we're the first to ever see this type of thing. And so the fear is that a health system where people work in this space because they have good intentions, they're going to step on a landmine. They're going to realize, like, shit, like, in many cases, these things are implemented. Like, they're affecting patients. They may not know that the landmine was there. Something may become public, and we're going to get to this, Jenny, but then the sirens come on from the popo of...
you did say popo.
Yeah,
that's your word.
Where did you just walk? And we're like, I didn't know. Like, yeah.
So
that's what people are scared of.
So in essence, people are scared of if they do something wrong, that the federal government's going to come down hard on them. There's going to be financial implications. There's going to be harm to their reputation. Like they don't want to be ID'd as a health system or a provider who is supporting some biased, racist AI.
Yes. And Dan, the worst part is, in the cases that we've talked about previously, when you're building it yourself, and you're like, something I just built myself, I can now show it perpetuates bias or discrimination. I mean, it forces...
Now, how does that feel? You've done it?
Yes. No, and this is where it forces a very uncomfortable internal dialogue with health system leaders to recognize what is in the data. And the reason it's in the data is because it occurred in practice. But so in many ways, contending with these questions is forcing a reckoning that I think has implications beyond AI.
A reckoning that's been a long time coming.
Yes, should have. We're late, to say the least.
And so Jenny, so when you hear that, particularly, one of the things that stands out to me about what Mark said was, like, we interviewed 90 people, we got 90 different answers. What is, and again, I know you are limited, and that's fair, like, that's completely fine. You're limited in how much you can say, but when you hear that, what do you hear, and how do you then think through the applicability lens of making sure that you are going to create something that will be useful and meaningful and actionable?
Yeah, I want to come up a level and just remind folks, the FDA and ONC very much are on the developer side, and we use the analogy of the ingredient list, right? So if the FDA looks at the developers and the makers of those ingredients, and ONC looks for transparency in the algorithms and makes those ingredient lists available to hospital settings and providers, what OCR is trying to do is say, hey, when you grab that product from the shelf and you look at that list, you also are an active participant. That is what the goal is. We are a law enforcement agency, but that is by no means to sound the alarms and getcha and do all these things. That is really no popo. But we are trying to make sure that as Mark has done so well with, if you guys have not listened to the podcast, please do so. You'll hear all about Mark's experience with the septic analyses. But to be an active participant, to say, oh, this does not look right to me. That if you are a physician who has 25 years of experience and suddenly the AI algorithms are telling you something very different from your medical training, don't just go with the machines, right? Be an active participant. And that is what we are hoping to accomplish, that is a reminder. And I know that that sounds very kind of, oh, of course, but our experience has shown that that is not the case necessarily. So this is just a reminder that non-discrimination laws exist, that we will, through our compliance efforts and through complaints that may be coming to hospital systems, work with you all. And I want to just say, as this rule gets promulgated and we work on our enforcement side, if you get a letter from OCR saying that a complaint has been lodged, here are the facts based on the allegations, to please do work with us. That is not a mandate to say, oh, we're pulling your federal funding, that's it, and wash our hands of it. It is really to learn. Sometimes it might be an invisible landmine that the providers did not mean or know that that existed. So it should be a dialogue at that point too, not only all of the dialogues that are currently existing that we've talked about this morning, but at that point, right, in the post-enforcement stage to say, oh, we did not know this. Here's an example from our perspective. And then we work with you all. And we do this in the HIPAA space. We do it in our non-discrimination space where we say, okay, what are your policies and procedures? Let's develop those. What kind of trainings are you doing for your staff now that this has happened? What kind of audit procedures do you have so that this doesn't have to happen again? I really implore, if there's one takeaway, is to not think of us as kind of the popo, but as a partner through our enforcement actions, because then the next step, and coming back to the COVID example, is that then we can actually use that as guidance to help industry and the public understand what's happening in these instances. So that's really our goal.
And so, Jenny, what is it you feel like, this has obviously been a question that we've asked the other two agencies as well. What is it ideally, what is it that the regulated entities, what do you want, what do you need from them to help ensure, again, because everybody in this room agrees, we want to ensure there's no racial bias in AI. What do you need from the regulated entities to help you realize that goal?
Sure, I think
step cooperation really mean?
Right. So step one already has happened. So many of you have already commented on the rule. We have gotten over 50,000 comments for Section 5057 alone. And that's just not an all AI, but just to let you know why it's taking us a little bit of time to go through and make sure that the rule is indeed as reasonable, as applicable, and as enduring as possible. And then secondly, when you see the rule, our goal is to not just leave you with it. It's to have a rollout, to talk to industry, to talk to stakeholders that care, to talk about moving up the 3-star rating and applicability to a higher level. And then after, as you implement the rule, to continue to have a dialogue with us, that this doesn't end today. And I just want to say, because I'm a civil rights attorney by training, right? things are not linear. We're not going to get it perfect, and you all know that, right? It's not going to look like this. Oh, great, like everything is fine. And that goes for the government side of things. That goes for industry. That goes for the public. There's going to be some ups and downs and bumps along the road and learnings that we have to kind of apprise ourselves of. But I think the key thing is to make sure that communications are open. OCR has a terrible website. It's very government looking, hasn't been updated in a while in terms of look, but we are available. Our complaint portal is available. I would say to utilize that, and also, obviously myself and our team are always willing to take meetings, same with our HHS partners, to talk through, what is working, what is not, because obviously we don't want this to be static and held in time.
So I do want to make a comment about applicability. I want to kind of use a concrete example. So let's talk about sepsis. Suchi was on stage earlier this morning talking about sepsis. I don't think it's a random chance that Suchi at Hopkins has done a lot of work building sepsis algorithms. My team at Duke, we've done a lot of work building sepsis algorithms. You have these highly resourced organizations that have technical, clinical capabilities that they can bring together to evaluate algorithms, and if something on the market is not sufficiently meeting their needs, to develop it internally. In Health AI Partnership, we have organizations that have far fewer clinical or technical resources. We have organizations that have had to pull out of their involvement because they couldn't make time for interviews or for participation in workshops that we were conducting. And one of my biggest concerns when it comes to applicability, and a consistent message every time I've been fortunate to be in this city, is trying to emphasize the need for technical assistance, because like it or not, the health systems that are going to have the hardest time evaluating potential for bias or discrimination are the lowest resources. They're the most likely to depend on external kind of procurement for adoption of AI, and they're the most likely to end up on landmines that they are not aware of. And so, yes, at Duke, we can, and the podcast is we evaluated this algorithm, we decided not to use it. We went with this other thing instead. But the reality is most places aren't going to even be able to do that. So in addition, this is where I think this is outside of your control. So I'd want to kind of share this message with other regulators. These regulations have to come with on-the-ground support for health systems. And maybe not even use the term system, just healthcare organizations, which may be remote critical access hospitals, clinics that are not going to be able to do sophisticated analyses.
To that, really appreciate that point, Mark. To that point, Jenny, obviously one of the clear messages that you're coming today with is you want to engender trust. You want to signal we at OCR are partners and we want to collaborate. We do not want you to be afraid. Is there anything that you can do to offer this technical assistance that Mark is talking about? Is that even appropriate for OCR? So that's one question. And the other question is, what other steps, understanding how new this is, understanding the technology, understanding the harms, that, again, going back to Mary, the harms are real, the harms are happening. There's urgency here. How are you thinking about what you can do to engender trust and ensure that people are protected?
Sure. I do think, we have been our enforcement teams have been working in this space throughout, and technical assistance can be available, of course, dependent on a fact-by-fact scenario. I think that we certainly work when there is a complaint lodged with larger entities who have far more resources, right? Like Mark is very lucky to be at Duke and many of you at this conference, but we also appreciate that there's single providers who might be using this technology, not knowing what's embedded in it, and then gets caught by a complaint with their patient. So we are absolutely willing to work with those providers. Again, going back to, it is, we are really looking to see if there's bad faith imbued here. We understand that there's some trial or error associated with this, but we are looking to say, oh, are you training your staff appropriately to look for this? Are your providers having an active role in implementing this AI? Do you have audit mechanisms to some degree? And I understand that if you're a small, physician's office, that might not be necessarily feasible in the first instance. But once that has been identified, are you then going to look at that, right? Will you put implementations into place? So we absolutely want to work with providers here. Again, we don't want to be punitive. As far as engendering trust, we have continuously not only just put out, of course, the rule and asked for comments, but continued to have roundtables and engage with industry, had multiple conversations consistently about just coming up a level, putting Section 5057 or any rulemaking aside, how we can collaborate and work together. And I really urge, so much of this is going to be about communications on the back end of things. Once the rule is out, engaging with Mark and telling us what we need to do more, what doesn't work on the ground. We have some, we're as close, going back to the idea of we're the closest agency speaking today with the end user, with the patient, but we still don't see the same things that you all will be seeing. So we need to rely on you to tell us so that we can get this right. And perhaps right is, defined differently across the board, but as right as possible, along with the bumps in the road.
The Marys of the world are counting on this. The Marys of the world are counting on you and you figuring this out.
And Dan, I do want to make a comment on enduring.
And let's do it real quick because I want to get to audience and I want these people to get to their lunch.
I think enduring is 5 out of 5 stars. And something I did learn from Jenny in our calls was, as someone responsible for complying with her and her team's rule, I want specificity. I want to know exactly what to do. She's comfortable with definitions evolving over time, that we're going to have to see cases of this, that standard is going to have to evolve over time. So I think we're aligned in, we're going to put something out there through Health AI Partnership that today may look different than it does next year, 2 years from now. But I think there is alignment across the ecosystem, regulator, regulated, to continue to refine the way that we avoid bias and discrimination.
Great, thank you. Again, I want you guys to get to your meal. Do we have questions? Any questions here? If not, I will ask. Great.
Hi, I'm Terry Bills from the Utah Department of Health and Human Services, and I wrote it down because I'm much more eloquent when I write. In medical practice, there's a common saying that if you hear hoofbeats, think horse, not zebra. AI logic tends to follow this model and finds the most likely solution and not necessarily the correct one. Are there any measures being taken to ensure that those of us, myself included, with rare or ultra-rare conditions are not misdiagnosed and mistreated because AI logic won't think zebra?
So that's a very good question. So generative AI, foundation models aside, most AI in use today is task-specific with performance measures that are very task-specific. So this could be looking at kidney function, a diagnosis of sepsis. It could be any diagnosis or medical condition and its progression or its existence. A phrase that one of my collaborators told me is ML is incredibly stupid. It only does exactly what you ask it to do. So the reality is there may be models that people build for rare or ultra rare conditions. Those may help. Things built for sepsis or kidney disease, not only are they going to be helpful for rare or ultra-rare conditions, they're not going to be helpful for anything other than exactly what they were built for. So this does kind of get to Mickey's point of the caution of how not to use it. Unfortunately, unless if there's investment to build things for those use cases, I think any effort to use existing solutions for those use cases is going to be pretty limited.
Great,
Thank you.
you.
And, thank you. And just this final question, let's do it quickly. Again, just to stay on track as much as we can.
Not really a question, but it's just an idea for some thought leaders in the room. So I represent an FQHC lookalike, and I felt compelled by Mark's comment to come up here and represent, because I think we're more in the trenches at the FQHC outpatient primary care standpoint. But I can't express enough as we go on to this journey to align with CMS and the insurance agencies, because it's great that we call Pandora's box. So AI can open Pandora's box of all these predispositions and conditions that this patient may have. And there's no worse thought in the trenches from a clinician when they try to do the right thing, but then the patients end up not going because the insurances aren't recognizing it. So I want to make sure that that is aligned as we go on this journey, because we can document in our notes that it was recommended, but in reality, it may not happen.
Great.
So
Thank you.
Thank you for that.
Thank you.
Thank you for that. Okay, let's give it. I apologize. We've got to go. Let's give it up for Mark and Jenny. And before you leave, if you would indulge me, I want to you guys can stay or you can whatever you want to do. If you'd indulge me and stay, I'd love to do this last poll thing. We've spent 2 hours hearing regulators and industry officials dig in on the challenges and opportunities for practical regulation that reduces bias in AI. So let's bring back that poll question. Are you confident that federal agencies and industry can work together on AI regulation that fosters innovation and protects against bias? Please pull out your phones, pull up the Whova app on the homepage, find that button that says polls, click on that, scroll down to the bottom. There are 2 of these questions. Scroll down to the bottom and tap on the last question, which should say, again, are you confident that federal agencies and industry can work together on AI regulation that fosters innovation and protects against bias? And I'll look at the results.
And while you're doing that, let's give it up for Dan.
Thank you. Okay, I'm looking at this. And we don't have the exact same numbers, but the yeses, but the bar, there's more yeses now than there were before. Everybody's got to go. I just want to say, final thing. I know people got to go, but like, this has been amazing. This is an honor. Thank you. Thanks to all of you for taking this seriously, for caring about this issue, and I wish you all the very best as you think about bias in AI and making sure that we were protecting the Marys of the world out there. Thank you. Have a good day.